So I would like to welcome everybody, good evening everybody, to this series of hematology webinars sponsored by the Saudi Society of Blood Disorders. Today our topic is about cutaneous T-cell lymphoma, a very interesting rare disease where multidisciplinary approach is much needed. So we have a multidisciplinary meeting today. We have dermatology, hematology, and transplant physicians to present this webinar. We have a large number of attendees and just few housekeeping recommendation for our participant. Please mute your phone, microphone when you're not talking. Also the camera, you're free to shut it down. The webinar is split into 3 parts. The first part will be presented by Dr. Yousef Binamer, a consultant at King Faisal Specialist Hospital. He will present the dermatologist aspect of cutaneous T-cell lymphoma. This will be followed by a talk for another 15 to 20 minutes by Dr. Ahmed Absi. Dr. Ahmed is a hematology consultant at the National Guard Jeddah. And then after that, we will have our famous international speaker, Dr. Francine Foss, who's joining from the United States, who will talk about the advances in the management of cutaneous T-cell lymphoma. Meanwhile, I'll be collecting the questions from the attendees, and at the end, we will have around 30 to 40 minutes of questions and answers. So this webinar is arranged by the Saudi Society of Blood Disorders, and this specific one, the cutaneous T-cell lymphoma, is sponsored by Kyowa Kirin, which is a Japanese company with special interest in rare disease and hematology and oncology drugs. Without further delay, I'm happy to introduce our colleague, Dr. Yousef Binamer. Again, Dr. Yousef is a consultant dermatologist at King Faisal Specialist Hospital. He will talk about the dermatology perspective in the management of cutaneous T-cell lymphoma. Dr. Yousef, please.
Thank you, Dr. Riad. Thank you for the Saudi Society of Hematology for hosting such webinar. Bismillah ar-Rahman ar-Rahim. Good evening, good afternoon, or even good morning, ladies and gentlemen. I would like to present a brief about the cutaneous T-cell lymphoma. We will do about the introduction, followed by a little bit of epidemiology, our experience at King Faisal Specialist Hospital, and then we'll talk about the clinical presentation and just touch brief about the management overview, and we'll discuss a little bit of few cases. So cutaneous T-cell lymphoma is a general term for any T-cell lymphoma that involves skin. It can involve the blood, lymph node, or any internal organs. The main symptoms are dryness, itching, skin rashes, or even enlarged lymph node. Usually they are present in the early stages, which are indolent, slowly growing, and is the vast majority of cases we see it in dermatology, and it represents around 70%, and most of the time they only affect the skin. However, sometimes it becomes an advanced disease where it becomes very aggressive and fast growing, and patient might progress rapidly, and it will cause 10% of these patients, they might develop very serious complications. Generally, the incidence of cutaneous T-cell lymphoma has been increasing over the time till the 1990, and then it becomes a plateau to the incidence around 10.2 million per person. And the cutaneous T-cell lymphoma is slightly higher in males in comparison to females. And also there is some differences in the ethnic background. For example, the African Americans, they are more likely to have the disease in comparison to the others. But here we have to be careful that sometimes when you have a darker skin complexion, especially even in our community, so we will see that the hypopigmentation and the pigmentary changes are more common. And this is for different reasons. Is that the contrast and the clear of the color become hypopigmented, where people sometimes they are afraid it is vitiligo or albinism or anything that causes skin pigmentation, which is a stigma in some societies. This is why they do and seek medical advice. And we have more hypopigmented type here rather than in the United States on the white skin. So the most common types, we have the mycosis fungoides, which is represent around 75% of all the cases. And the rest are the other than cutaneous T-cell lymphoma. Sézary syndrome is representing only around 3%. However, it is very important because Sézary syndrome is more advanced and more aggressive, and where there is involvement of the skin as well as of the blood. While the most common type is usually the patch and the plaque type, which is the most likely seen in dermatology practice. So what about the cutaneous T-cell lymphoma in Saudi Arabia? We have published about our experience at King Faisal, and it is around 6 years retrospective study. We have identified 125 patients. The youngest was at age of 5 years, and the oldest was 85. And if you see again, it is a little bit more predominant in males in comparison to females. And if you go with what are the age group, you will see almost half of the patients are between the age of 20 till the 50, more than half of the patient. And here, for example, the highest or the incidence is highest in the age of 30 to 40, followed by 40 to 50 and 50 to 60. So middle age, it's the highest age to have such a disease in our society. So the next point is that what is the most common? As a dermatologist, we see the patch and plaques. And if you see the patch and plaque stages, which are we call the classic cutaneous T-cell lymphoma, is representing almost at least 50% of our cases. Moreover, we have a high incidence of poikilodermatous changes, where we have an atrophy, dyspigmentation, hypo and hyperpigmentation, and telangiectasia. It is a common in our society more than the others, as well as the hypopigmentation. The hypopigmented MF, most likely because of the skin complexion and because of people, they are afraid it is a vitiligo to avoid any stigma. So this is why we have more cases. So roughly between the patch, plaque, hypopigmented, and poikilodermatous changes, they all represent 80 or up to 90% of all cases. However, we have some cases of Sézary syndrome, a tumor stage, verrucous, hyperpigmented, granulomatous, erythrodermic, follicular type, CD30 positive lymphoproliferative disorders, including LYP and anaplastic cell lymphoma. All these we see it, but they are less common than the others. Again, it's very interesting to see the combination better, where we have a lot of patients where they do have poikilodermatous MF, in addition to the either plaque or patches or even hypopigmented. Some patients who do have hypopigmented MF, they do have patches and plaque types as well. So mixed is seen is very common. So we mentioned this, it is the most common is the classic type, followed by the hypopigmented and then the poikilodermatous type. And it's very interesting to have that we have 4 patients who do have also rheumatoid arthritis. So I will be very concerned if I have a patient with rheumatoid arthritis with the skin rash that is persisted for a period of time. So I will do biopsy because I have seen that we have like 4 patients who do have rheumatoid arthritis and develop cutaneous T-cell lymphoma. Also the association between solid neoplasms and cutaneous T-cell lymphoma is very well known in the literature, and this is we have seen a few cases as well. The general classification of cutaneous T-cell lymphoma based on the WHO, we know that it is either mycosis fungoides with folliculotropic or vegetoid reticulosis and granulomatous, Sézary syndrome or adult T-cell leukemia and lymphoma, A primary cutaneous CD30 low-positive lymphoproliferative disorder, we see it in our society, but it's not that common. And most of the cases that we have it either preceded by a lymphoma or cutaneous T-cell lymphoma. Ventriculitis type T-cell lymphoma is also uncommon here and sometimes misdiagnosed as lupus. So any patients who present with lupus ventriculitis only, we have to be sure that we don't miss ventriculitis like T-cell lymphoma. Extranodal NK T-cell lymphoma, usually they don't present to dermatology, mainly to present to hematology. Also, the other types of peripheral T-cell lymphoma, they are uncommon here. I haven't seen, maybe because they are more aggressive, they will go to the hematology or to the oncologist. So whenever we see a patient with cutaneous T-cell lymphoma, we do for them modified severity weighted assessment tool, where you do calculate the body surface area for each, the patch, plaque, and tumor. In dermatology, we have a Absi score for psoriasis. It's similar to this, where you have the body surface area and it is multiplied. It depends, is it patch or plaque or tumor. It's very important to assess the disease at the beginning and during the treatment as well. And here, a specific body surface area, maybe use rule of 9 or the patient palm. So the patient palm itself is representing 1% of the body surface area. When you do the staging for cutaneous T-cell lymphoma, stage 1A, where we have involvement less than 10% of the body surface area. Stage 1B, when they involve more than 10% of body surface area. And here it's very important to differentiate when they're involved more than 10% of the body surface area. Is it a patch where you don't feel anything, it's just a flat, or there is elevation? If it is more than 10% of the body surface area with the plaque type, it has to be treated in a little bit different way than if it is patch type, which is the flat one. And then you need to check your lymph node. If it is reactive, then it will be stage 2A. If there is a tumor where you have elevation more than 1 centimeter and it is more in depth, this is the tumor stage. And when you have an erythrodermic where you have more than 80% of the body surface area is involved with redness, and this is very, in dermatology, whenever we have patients present with erythema all over the body, it's a wide differential diagnosis, because erythroderma, which is erythema all over the body, is not a diagnostic per se. You need to know what's the reason. Could be drug reaction, could be eczema, could be psoriasis, or could be skin lymphoma. Here we have we need multiple biopsies to be sure that we don't miss erythrodermic cutaneous T-cell lymphoma. And then we have to assess the blood. If there is blood involvement with the high burden blood involvement, then it is a Sézary syndrome. When there is a lymph node involvement, then it will be a lymph node involvement or even metastatic disease. Always when we see the patient, the first step, if it is patch or a plaque, because it will determine my treatment. Usually the patch stage or the patch type, the flat one, is responding very well to treatment. The plaque, it needs more aggressive in the form of different way of treatment. Workup, generally, since we are seeing low-grade lymphomas or early stages lymphoma most commonly, we do the main thing is skin biopsy to confirm the diagnosis. Sometimes we need more than one biopsy to confirm our diagnosis. And we do a baseline investigation, including the white blood cell count and LDH. We don't need to do any imaging in the stage 1A and stage 1B if there is no plaque type. If it is extensive stage 1B with the plaque type manifestation, or there is any feature in the history, for example, weight loss, palpable lymph node, then imaging is required. If you have a patient with the suspected erythrodermic or type or Sézary type cutaneous T-cell lymphoma, then you need to do peripheral blood morphology looking for Sézary cells. You do also flow cytometry with CD4, CD8 ratio, CD27, CD26, as well as CD7 to see if there are loss of the positivity of these cells. One thing also, we do it sometimes for advanced stages, or if there is like any signs or symptoms on physical exam and history, we do PET-CT as well. So since we have cutaneous T-cell lymphoma, the most important question all the patients are going to ask, what is the prognosis? We say that for the early stages of cutaneous T-cell lymphoma, the prognosis is very good and excellent. Actually, it's almost compatible with the normal life. However, with the advanced stages, the 5-year survival becomes low and low. For example, the advanced stage, the 5-year survival, it's approaching 25% only. This is why it's important to treat cutaneous T-cell lymphoma, especially in the early stages, and to avoid any medication that has some side effect, because you don't want to have side effect on the patient more than the effect of the disease itself. However, in the later stages, or when the disease is aggressive, you need to be aggressive in treatment. And for advanced stages, even transplant should be tried in the young, healthy patient, because this is a very difficult to treat disease, and the cure is very low. So for the prognosis, for the early stages, there are some studies that show, we call it the Cutaneous Lymphoma International Prognostic Index for the early stages. For example, if you have a male elderly with a black type, with lymph node involvement or folliculotropic, it has a little bit worse prognosis. What we mean by folliculotropic means that when there is involvement of the hair follicles. Whenever there is involvement of the hair follicles, sometimes you will do areas of the hair loss, and it will be a follicular. That means the T cell abnormalities and the malignant T cells are invading the hair follicles. In this stage, we treat this condition as if it is a tumor stage, because you need something to penetrate deep into the hair follicles. So if they do have only one risk factor, they are considered as low risk, and the 5-year survival is very high, 96. If they do have 2 risk factors, it will be medium, which is 5 years, it is 87%. If they have 3 or more, the 5-year survival is 73. This is mainly for stage 1A, stage 1B, and stage 2A, where you have only reactive lymph node. But if you have the patient with the advanced stage, where they do have a tumor stage and beyond, we think about the gender, the age, if there is blood involvement, or the lymph node and the visceral. And here, if they have one risk factor, the one risk factor we call low risk, the 5-year survival is 63%. If they do have 2 risk factors, the 5-year survival is 37%. And if they have 3 or more, it is high risk with around 22% 5-year survival. These prognostic factors in the later stages have been restudied, and they found the most independent 4 factors. And the most independent 4 factors are advanced stage, stage 4, elderly age more than 60 years, increased LDH, and large cell transformation. So these 4 factors are the most important, and these are the independent factors. So whenever we see a patient with advanced stage, now we consider these, the 4 prognostic factors are the most important. And then again, if you have 0 or 1 risk factor, it is 68% the 5-year survival, and this will be reduced to 40% if they are 2, and they are 3, the risk will be 28. This is very important to look what are the definition of the large cell transformation. Whenever you have a patient with cutaneous T-cell lymphoma and he presents with sudden onset of multiple ulcerative nodules, and he is sick, he has some symptoms, then you need to rule out large cell transformation because it needs aggressive treatment. So there is a definition in pathology where you have more than 25% of the cells are large lymphocyte and they form an aggregate, and the large lymphocyte means double size the normal lymphocyte. So the survival rate mainly for the advanced stages here, as we mentioned earlier, if it is a tumor stage, 57%, the 5-year survival. If it is erythrodermic, 58%, and if there is involvement of the blood approaching 40%, and there is involvement of the organ, internal organ, then it is around 39. However, if they are high risk patient in the high risk group where there are 3 risk factors, for example, age, increase in the age, transformation, and this will decrease the 5-year survival up to 28%. Treatment modalities.
3 minutes. 3 minutes,
Okay,
Dr. Yousef.
3 minutes, that's okay. So treatment modalities, I would talk in general in dermatology, we are focused on the skin because the skin is the source of the disease. We use topical. Mainly we start with narrowband UVB for the batch stage. If there is a plaque stage, it's preferred to use PUVA. Sometimes you could use methylmalstat, but it is very expensive. Topical steroid had been used. The other systemic therapy that you could use you could use bixarotene and retinoid, interferon as well. If there is blood involvement, ECB, extracorporeal photopheresis is one of the important things. Usually we need adjunct therapy together. Usually it is a lifelong treatment. There is no curative treatment. The role of the chemotherapy is, if there is any role, it is only in the later stages. The main stages in the early stages is to treat with topical and either with skin-directed therapy with phototherapy. The PUVA, it has much improvement and much result because it penetrates deeper. So I wouldn't go into the medication. A few cases just to see it. This is only skin involvement, limited. It can respond to topical or excimer laser. This is more advanced stage 1B. I will give him here PUVA. If not available, maybe narrowband UVB. Here, the hypopigmented in children, maybe narrowband UVB is the option. Here, a lady with the tumor stage, mycosis fungoides. Here, she needs a systemic therapy and also she received radiation to the tumors. If the patient is candidate for transplant, then it will be good. Targeted therapy to target chemokine receptor 4 or even histone D acetylase, these to be considered a third of the conventional treatment. This is what we mean by sometimes folliculotropic, where you have a hair follicle involvement leading to hair loss. Here, sometimes you use PUVA or even interferon. And this one is the poikilodermatous changes. Usually they carry excellent prognosis, but the problem here is more of cosmesis because these are permanent and no changes.
1 minute.
Lymphomatoid papillosis with cutaneous T-cell lymphoma. Usually we give them methotrexate or brentuximab for these stages. Again, the same thing. This is erythrodermic, where it has proven to be erythrodermic cutaneous T-cell lymphoma. However, the initial biopsies were only eczematous reaction, but on further biopsy and the subsequent biopsy, it's proven to be cutaneous T-cell lymphoma. This is 1B stage of mycosis fungoides. I will treat with narrowband UVB. Here is folliculotropic mycosis fungoides, which is progress in the later on to involve a Sézary syndrome, and he responded very well to extracorporeal photopheresis. This is a Sézary syndrome, very common to have bones and cells involvement. This is the advanced tumor stage, and thank you.
Thank you, Dr. Binamer, for being on time. So we've heard from Dr. Yousef about the dermatologic aspect of this disease. We will keep the questions and answers till the end. We've got a few interesting questions to ask Dr. Binamer. Now we'll move to Dr. Ahmed Absi. Dr. Ahmed, again, is a consultant at National Guard Hospital, Jeddah, Saudi Arabia. He will talk about hematologic approach to cutaneous T-cell lymphoma. Dr. Ahmed, please. You need to unmute yourself.
Thank you, Dr. Riad. Let me share my screen. Can you see my talk right now?
Yes, yes, we can see it.
Okay. Again, thank you, Dr. Riad, and I appreciate my invitation. So I was asked to talk about systemic therapy for cutaneous T-cell lymphomas, and Dr. Yousef really made my job much easier with his excellent presentation. I don't need to go or dwell much on the initial slides, but again, given the fact that for us hematologists, we don't see this disease that common, so it's not bad to remind ourselves. In the WHO, our book of cutaneous classification of cutaneous T-cell lymphoma or NK cell lymphomas, this definitely includes multiple diseases. Mucosis fungoides and its subtypes is definitely the one that is most common and the one that most of our talk will be directed towards. But it's important to remember that other categories do still exist, and every once in a while we will see patients presenting with things like primary cutaneous CD30 positive lymphoproliferative disorder or subcutaneous panniculitis like T-cell lymphoma. There are other provisional categories as well, such as, for instance, we recently actually had a case of gamma delta T-cell lymphoma cutaneous. Now, mycosis fungoides and Sézary syndrome are the most common subtypes of cutaneous T-cell lymphomas. And as I said, the talk will mostly be directed towards them. Now, MF is a mature T-cell non-Hodgkin lymphoma with a presentation mainly as shown by Dr. Yousef in the skin, but it has potential of involvement of other nodes, blood, and viscera. As Dr. Yousef has shown, it's mostly skin lesions in the form of patches, plaques, could be localized, widespread, could be either tumors or erythroderma. On the other hand, Sézary syndrome is, though it's very closely related to MF, but does have very unique characteristics. We have to understand that this is a rarer form than MF. The hallmark of Sézary syndrome is the presence of atypical T cells, which we call the Sézary cells. They could be present either in the skin, causing diffuse skin erythema or erythroderma. And this is usually accompanied with a blood involvement, or actually always accompanied with a blood involvement with the same abnormal T cells. They have to be more than 1,000 abnormal cells in the microliter, defined as Sézary cells, either by cytopathologic assessment or by flow cytometry pattern, which are CD4 positive, CD7 negative cells, or CD4 positive, CD26 negative cells. Now, it's worth mentioning that the origin of Sézary cells is thought to be thymic memory T cells. On the other hand, the mycosis fungoides cells are skin-resident effector memory T cells. This all raises the notion that the SS is a process distinct from MF. So they're not necessarily the same disease. The origin, cell of origin is different. As Dr. Yousef has shown, the staging of cutaneous T-cell lymphoma is actually two-step system. Step number one is we stage the disease site. And we as hematologists are usually involved when the disease site is more advanced, either with a visceral involvement or blood being B2, which is high blood tumor burden. Now we take that forward to the TNM staging system. And as I said, the hematologist, we are usually involved in the advanced stages, which is usually defined by either B2 blood involvement or by visceral involvement, so M1 disease, or a nodal, which is the N3. Nodal is usually a pathological definition defined as higher grade cells present in the lymph nodes. Now, obviously, like all other lymphomas, staging is correlated with prognosis. And as Dr. Yousef has shown, not only staging, prognostic features as well, including older age, elevated LTH, and large transformation in the skin. I would like to mention just two subcategory pathological, which are important to know. Now, the first is the folliculotropic MF. Now, this is a variant of MF characterized by infiltration of the cells of the follicles within the skin. Why I'm mentioning this? Because this is associated with a greater disease risk of progression and worse prognosis. Yes, it's usually seen by the dermatologist, and they are very good at knowing that skin-directed therapy has to be or has to reach the subcutaneous tissue here. So things like PUVA or ISRT. We get sometimes involved because patients may fail or fail to respond to skin-directed therapy, and in this situation, they need a combination of systemic as well as sun-directed therapy. The other one is the erythrodermic disease. Erythroderma, which is defined as T4 lesion, is associated with 80% of the BSA with erythematous confluence of the lesion. It's usually associated with hair loss in areas of involvement, some scaling of the palms and the soles. The diagnosis is not always easy. Some of those patients has already been pre-treated with steroids, and maybe multiple biopsies could be needed to define them, to diagnose them. So general principle of treating those patients, three general principles really if to worth remembering. Number one, multidisciplinary care obviously is a must, like what we have today. It's not only the hematologist, not only the dermatologist, especially the advanced stage diseases. You need the involvement of three specialties, the dermatology, the hematology, and the radiation oncology. Also, evaluation of the pathology at a referral center is recommended. And indeed, in our country, I think it's a must, given the fact that we see low number of those cases, at least in the oncology centers. I'm sure that dermatologists see much higher number. But when the patient makes it to an oncology referral, I think sending those biopsies for expertise is not definitely not wrong. We talked about the follicular tropism. A large cell transformation has to be noted, and asking the pathologist about it from the beginning is of utmost importance, because directing the therapy towards that from the beginning is important. So what are the goals of therapy? Three goals. Number one, we need to achieve long-term disease control. Number two, prompt symptom relief. And number three, addressing the life-threatening disorders, which is the aggressive disease, such as the large cell transformation. These three goals go hand in hand throughout the therapy of the patient. So I've seen it not uncommonly when the patient gets referred to a hematologist for long-term disease control, prompt symptom relief gets forgotten about, and that's wrong, because the patient, at the end of the day, will need both at the same time. So how do we individualize the patient? Well, first of all, we need to attain adequate response in order to reduce and control the symptoms and minimize the risk of progression. We have to remember that most treatments for MS or SS do not result in durable remissions of treatment, and therapies with lower side effects profile and an absence of cumulative toxicities are often given in an ongoing or maintenance fashion to improve and maintain disease control and the quality of life. Other than allogeneic hematopoietic stem cell transplantations, therapies are not given with curative intent, and that's very important for patients to understand from the beginning. Generally, skin-directed therapies and biological agents with lower rates of immunosuppressions are used in earlier lines of therapy. Chemotherapy, usually single agents, are preferred over combination chemotherapy such as CHOP, given the fact that even with combination chemotherapy, those remissions are not usually durable, definitely with higher toxicities in the combination chemotherapies. We have to remember those patients, as they reach to the hematologist, they have large areas of skin involvement. They are at risk of multiple recurrent infections, and combination chemotherapy here are challenging. Responses can vary between different compartments, and that's very important also to note. Skin, blood, and lymph nodes may not respond all at the same fashion. Now, unlike other non-Hodgkin lymphoma subtypes, response criteria for MF and SS has not been demonstrated to correlate with prognosis, and also this is very important to note. What matters for patients at the end of the day is symptomatic improvement, and especially in the blood, in the skin. And often decisions to continue or switch therapies are based on clinical basis rather than radiological ones. Disease relapses after discontinuation of therapies may respond to retreatment with the previous therapy. And that's important to note. Some therapies, before they get thrown out of the window, it's worth retreating, especially if the response was significant at the first round of therapy. And partial responses with suboptimal quality of life, that's not acceptable. This should be treated with other or additional primary treatment options. Finally, the use of supportive care measures to minimize risk of skin infections and treat the pruritus is very important and makes a whole lot of improvement for patients. So for patients with advanced MF or SS, what are the systemic therapies available? This is the list. I think Dr. Francine will talk about most of them. For me, it's worth mentioning the brentuximab vedotin data, which I'm sure that Dr. Francine will allude. The famous randomized open label trial, which randomly assigned patients to either brentuximab vedotin versus the choice of therapy between bixarotene or methotrexate, has shown that overall response rate was more than 50% with brentuximab vedotin. Around 15% of those patients achieved CR, and the symptomatic relief, again, which is the most important, was achieved in 30% of those patients compared to 9% with bixarotene or methotrexate. Also, it's worth mentioning that with BV, the response happened regardless of the CD30 expression, and that's important to note. Again, another thing to keep in mind and not get rid of quickly is the issue of low-dose methotrexate. Low-dose methotrexate is an important in the armamentarium of therapy, and usually dermatologists will apply this therapy before referral to hematologist. So how do we choose between those agents? Selection of systemic therapy must be informed by prior treatment, and having a clear map of the treatments patients has been exposed to before is important. Comorbid illnesses is important as well, especially when exposing the patient to certain agents, knowing the toxicities of those agents, as well as the route of administration and the patient preference and convenience are all important. Now, immunopreserving agents, things like retinoid or low-dose methotrexate, or immunostimulatory like interferon, are usually preferred to be started with prior to the use of more toxic regimens. Most patients will relapse, and that's a fact, after initial treatment. And relapsed disease may respond to repeated therapy with the same agent or other skin-directed or systemic therapy. We have to understand that few clinical trials has directly compared systemic agents for treatment of advanced MF. Actually, besides, if I'm not mistaken, brentuximab vedotin and the megamyzumab, we don't have randomized clinical trials. So most of those studies compare side to side of the agents. And most other data regarding responses to systemic therapies are derived from modest-sized studies that did not directly compare agents. Now, what do we do with the aggressive disease? This is a disease we need to start with things like low-dose methotrexate or even exposing patients to chemotherapy, such as pegylated liposomal doxorubicin, single-agent gemcitabine, which has a very good response rate, but usually, very good symptomatic relief with low toxicity profile, but it's not long-lasting.
2 minutes.
Pralatrexate.
2 minutes, Dr. Absi.
Okay. Pralatrexate, if available, is also associated with good response rates, but again, is usually not long-lasting. Purine analogs usually is associated with infections, and many of those patients are prone for those infections. Relapse refractory disease is definitely more challenging. Again, most of those studies are single-arm, small studies with very few responses that don't last that much. I will leave Sézary syndrome for Dr. Francine to talk about because mostly it's treated with the newer therapies rather than the traditional therapies. Finally, I will just jump to the hematopoietic stem cell transplantation. Experience with hematopoietic stem cell transplantation in MF is limited due to small number of case reports and case series. Autologous really has no role. The response with autologous bone marrow transplantation is short-lived, and with an estimated time to disease progression of little over 2 months, and it's rarely used, really shouldn't be exposed. Allogeneic, on the other hand, has more evidence, and technically allogeneic BMT is the only long-term curative therapy that could be offered to those patients. The largest published data comes from the International Retrospective Analysis of Patients with MF, which only included around a little above 50 patients, either with MF or Sézary syndrome. In this trial, 75% received a match-related donor, and the rest were MUDs. 27% of them were myeloablative, and the rest were reduced intensity conditioning regimen. With a median follow-up of 36 months, the overall survival at 7 years was 44%. And it was worse for patients who were receiving MUD, clearly, and myeloablative, as well as advanced phase disease at the time of transplantation, raising the issue that earlier thinking about transplantation in patients with aggressive disease or large cell transformation is a must, because the later this intervention is left to, the more patient will get sick, and the worse the outcome on the long run. The acute graft-versus-host disease in this trial was reported in 40% of the patients, with a chronic GVHD of 50% at 2 years, and a non-relapse mortality of around 20%, which is technically in the acceptable range. The factors associated with non-relapse mortality, again, were myeloablative conditioning regimen and poor performance status at the time of hematopoietic stem cell transplantation. So fitting the allogeneic bone marrow transplantation within the schema of therapy for patients with MF or SS, as I said, the minute the patient makes it to the oncology center, if the patient is fit for this therapy, a search for a donor, especially if match-related donors, should be thought about. And taking this intervention at any moment when the patient shows unresponsiveness to multiple lines of therapy, not too far away within his disease, and any indications of aggressive disease like large cell transformation or other high-risk features if present in the patient. And I will end here. Thank you very much.
Thank you, Dr. Absi. We'll move on to Dr. Francine Foss. Dr. Foss is a professor of medicine at Yale University. She's very well known in the field of cutaneous T-cell lymphoma. She has more than 170 publications, multiple book chapters, all about cutaneous T-cell lymphoma. And she chaired many committees to draft guidelines how to treat cutaneous T-cell lymphoma. Dr. Foss will talk about the advances in the treatment of cutaneous T-cell lymphoma for 25 to 30 minutes. Dr. Foss, please. You need to unmute yourself, Dr. Foss.
Thank you very much. I'd like to follow on after those two very excellent talks to focus on some of the more updated therapies and treatment advances.
We can see your slides.
I'm just trying to advance the slide. Okay. So this is just a quick slide to review the different stages of disease. And I think we already talked about this, focusing in on the fact that many of the patients with earlier stage disease have a better outcome than those patients with tumors or with erythroderma. And we're going to focus a little bit on blood involvement in my talk. So I just wanted to introduce this slide. I don't know if many of us actually look at blood smears anymore. You know, it may be a thing of the past, but these Sézary cells, if you look at them in the blood smear, are really very interesting because they're hyperconvoluted, they're larger than normal lymphocytes, and if you look very closely, you can see this classic cloverleaf nucleus. And some of these cells can get quite large in the setting of large cell transformation. And so it's important to look at blood involvement in patients at all stages. And we talk a little bit about this at the ISCL and the USCLC meetings is, do we really need to get flow cytometry in the early limited patch plaque stage patient? And we feel, at least at the initial workup, that you should get a blood flow cytometry to ascertain whether there's any degree of blood involvement. So we went over this staging system, and I won't belabor it, but just to mention the fact that blood involvement is quantitated in the staging. And again, we went over the TNM staging, so I'll skip over this slide as well. Now, there has been some evolution in the assessment of blood involvement, looking at the quantitation of the number of atypical cells. And so B1 was classified by the ISCL, USCLC, and EORTC back in 2011 as greater than 15% or greater than 250 to less than 1,000 malignant cells per microliter as determined by flow cytometry with markers such as CD4 positive, CD7 negative, or CD26 negative cells. If you look at the new classification, we're simplifying that, B0, B1, and B2, to simply look at the absolute number of malignant cells. And so rather than the percentage, we're focusing on the specific number. So again, it's 250 to less than 1,000 for B1, and it's greater than 1,000 for B2. And B0 is interesting because B0 doesn't necessarily mean that there are no cells in the blood. These patients usually have less than 250 per microliter. And again, it's difficult when you see a patient and you follow them clinically, and you're getting flow cytometry and you're coming up with these small numbers of cells that are fluctuating, what you tell a patient about the prognosis. So at this point, we really don't understand much about the prognosis within B0, comparing patients who have virtually no cells to patients that have some cells. And that is something that the ISCL is hoping to study. Again, just impact of disease stage on survival. We went over this, so I will not belabor this point on my slides, but suffice it to say that those patients with tumor stage disease and erythroderma are the ones that we focus on for advanced stage, more aggressive treatment approaches. Again, we touched on the prognostic factors from the international retrospective studies. And those prognostic factors associated with overall survival were advanced stage disease, the LDH, age greater than 60, and large cell transformation. So the current status of treatment for CTCL in a nutshell is really summarized here. CTCL is an immunologically responsive disease, and we know that because we early on treated patients with interferon with very good results, and subsequently we've developed other immune modulatory therapies. Most of our approved therapies have a very low complete response rate, hovering in about the 10% range, and an overall response rate of about 30%. And most of our patients require multiple therapies over the course of time as their disease evolves. They may receive combinations of agents, both systemic and topical. And one thing to remember when we're treating our patients is that stable disease is a meaningful endpoint for many of these patients, if stable disease means that there's relief of symptoms such as pruritus or skin manifestations that cause discomfort. And then Madeline Duvik, a long time ago, told us that infections are the major cause of morbidity and mortality. And in fact, the major cause of death in the United States from patients with MF and Sézary is infection still. We have to look at patients longitudinally over time, and you can see in this curve that many of our patients are going to undergo a stage-wise progression, with the exception of the T1 patients. Many of these patients over time will continue to have their disease march on. And again, I think this is important information when you think about transplantation and implying a very aggressive strategy that has mortality associated with it for these patients with even extensive patch plaque disease. If you wait long enough, many of these patients are going to progress and become refractory to most of our existing therapies. And again, you saw this slide just outlining a therapeutic approach, which includes more conservative therapies early on and then evolution to more aggressive treatment strategies. So I just wanted to touch on patch plaque disease, because typically we think about advanced disease as being, again, tumors and erythroderma. But many of our patients with extensive patch plaque involvement do go on to develop more aggressive disease, and many of these patients can become refractory to therapy. So the therapeutic options for these patients include various light-based therapies or total skin electron beam radiation. And again, the biological agents such as retinoids, interferon, and histone deacetylase inhibitors are often very useful for these patients. We like to start off with the oral agents, but then for many of these patients, as they progress, they go on to the systemic therapies as well. And you can see a variety of different systemic options for these patients. In addition, as I mentioned, I have taken some of these patients to allogeneic transplant if they've progressed on beyond most of these agents. And so many of these patients do have quality of life issues. Many of them have infection-related issues. And again, for all of our patients, therapy isn't a one-shot deal. Therapy involves maintenance, which is really not as well defined in this population of patients. Just trying to advance my slide, sorry. Okay, so just focusing on tumor stage disease. Again, tumor stage disease may or may not involve large cell transformation. Many of these patients are CD30 positive, so it's important to know that and to look for CD30 when you do a biopsy on any patient with CTCL. Many of these patients will go on to receive localized radiotherapy for palliation, but again, radiotherapy isn't going to cure most of these patients. And so they sequence into some of the systemic therapies. And the newer agents, such as brentuximab vedotin, are particularly useful in this stage of disease. And in addition, mogamulizumab has been associated with responses in tumor stage patients. Many of these patients require multi-agent chemotherapy to debulk them. And so oftentimes we will use combinations such as gemcitabine and Doxil, Gemox, or even EPOC for patients with very aggressive disease. And again, these are the patients that oftentimes will move on to a stem cell transplant. It's important to recognize large cell transformation because, again, that's an important prognostic factor. The NCCN guidelines for tumor stage disease, again, just direct us to the various systemic therapies and the use of radiotherapy if needed. And again, patients will segue on from one systemic agent to another, and then a fraction of those patients will end up with a transplant. The agents that are in the NCCN guidelines are based on the level of evidence. And the first group of preferred agents include brentuximab vedotin, bexarotene, photopheresis, interferon, methotrexate, mogamulizumab, romidepsin, and vorinostat. And then you have agents like gemcitabine, which is still a really good drug. In fact, it's a drug that I use very often in these patients, and I've seen some very dramatic responses. Likewise with liposomal doxorubicin. And then you've got other agents we won't talk much about, even an agent like temozolomide. The phase 2 showed there was some activity. And likewise, pentostatin is an old drug that's had activity. Sometimes we really need to go back to pentostatin because patients have been through all the other drugs. So, Sézary syndrome. Again, this is a very small number of patients, percent of patients that we see. Diagnosing Sézary syndrome outlined here by the ISCL EORTC, and they defined the presence of erythroderma as erythema covering a greater than 80% of the 1,000 cells, or an increase in CD4 positive cells with an abnormal phenotype. And again, the typical abnormal phenotype is CD4 positive, CD7 negative, but also there are patients who could be CD7 positive. So CD26 is oftentimes a useful marker to identify that group of patients. Well, Sézary syndrome is a difficult situation to manage because many of these patients present with extensive erythema, pruritus, oftentimes infections, and impaired immune function. So oftentimes the first therapy we would use would be an immune modulatory therapy, such as photopheresis or interferon alpha, or bexarotene, or one of the other retinoids. In some of the older patients, we may use methotrexate, which can be palliative. But fortunately, we have a panoply of new agents that show activity in Sézary syndrome, such as romidepsin and mogamulizumab, and then we have Campath. In addition, many of these patients do require prophylactic antibiotics, so oftentimes I'll put them on courses of Keflex. And I try to avoid central lines due to the high risk of sepsis. One of the things that I do is when I'm treating a patient with Sézary syndrome, I generally place them on prophylactic acyclovir and PCP prophylaxis, and they continue on that throughout the course of their therapy. NCCN recommendations, I'm just showing you here. I won't go through in detail, but again, many of these patients sequence through these therapies, and then at the end of the day, you can see in the red box that we would like to try to take them to allogeneic transplant if it's appropriate. And for the Sézary syndrome and erythrodermic CTCL, the NCCN recommendations include various combinations of topical and systemic agents, as well as those newer agents that have shown activity, particularly mogamulizumab and the HDAC inhibitors. And this is just a summary of the FDA-approved treatments for relapsed and refractory CTCL. So romidepsin is still a very active drug, and it's a drug that I use often. In fact, it's typically the first systemic drug that I will use in a patient with advanced patch plaque disease or erythroderma. The response rates are 24% with a very small complete response rate. Detalucan diftitox was called ONTAC and was an active drug for patients that express CD25. Now that drug came off the market, but actually is going to be coming back in a newer form called E7777, which is completing clinical trials. And then bexarotene just by itself has a response rate of 30%, sometimes still used as a single agent, but oftentimes I use it in combination. And likewise with vorinostat, interestingly, in the original pivotal trial, the response rate was 30%. But in subsequent randomized settings, the response rate actually was much lower than that. And then we have brentuximab and mogamulizumab, which we'll talk about. So I just want to say one word about photopheresis, because photopheresis is a treatment that we shouldn't forget about. It's certainly very good for patients with circulating cells and erythroderma, but I've even used it in some of my earlier stage patients as well. And this slide just shows you that photopheresis by itself perhaps doesn't have an impressive response rate, but when it's combined with other biologic strategies such as interferon or interferon plus retinoids, or I should also say interferon plus retinoids plus vorinostat, you can see that the response rate to photopheresis is significantly higher. And in fact, in our institution, we generally try combination therapy, starting off with interferon plus photopheresis, and then adding the other agents if needed. Campath has been around for a long time, and I just want to remind you that it's still an active drug. There were a couple of studies that were done looking at Campath as a single agent with different dosing schedules, showing a fairly high response rate of 85 or 84% respectively. But again, as you might expect, there's a high incidence of infectious complications in these patients who were treated at these higher doses of Campath. There's another study where patients received Campath sub-Q, and it was tolerated better that way. And in fact, using lower doses can be effective as well. So again, Campath is an agent that I sometimes use. In fact, I've had a couple of patients that have failed all of the above agents that I've talked about, and they ended up responding at the very end of the day to Campath, which proved to be then a segue to allogeneic transplant. Pralatrexate was a drug that was approved for peripheral T-cell lymphoma, and this is a study that we did in the United States looking at it in CTCL. And we used different schedules and different doses, and you can see the response rates were fairly high in this small group of patients. And so what we generally concluded from this study is that the target dose should be 15 milligrams per meter squared, given for 3 weeks out of 4. And that is the schedule that we're now using in our patients in the United States. Brentuximab vedotin, of course, was recently approved for CTCL based on the Alcanza study, which was a randomized trial comparing brentuximab to physician's choice. And these were patients with MF as well as primary cutaneous anaplastic large cell lymphoma. You can see that there were 131 patients randomized in the trial. And if you look at the improvement in skin measured by that skin MSWAT score, you can see that the drug is really pretty effective in MF, in that almost all of the patients had some element of response in their skin. And you can see many of them had at least a partial response. As opposed to methotrexate or bexarotene, where you can see the response rate was more modest. Sorry. Okay, so the comparison of progression-free survival showed clearly that brentuximab, which was much better than bexarotene or methotrexate. And so brentuximab therefore has really been used fairly extensively in the United States. And of course, because many of our patients are CD30 positive, we've been able to use it across the spectrum of disease. The question comes up about the level of CD30 expression. And there were actually 2 phase 2 trials done, one by Dr. Duvik and one by Dr. Kim, that looked at different levels of CD30 expression and showed that even the very low levels of 5% or less could be associated with a response. And so although we do determine CD30, we do it by immunohistochemistry in all of our patients, I don't necessarily use the level of CD30 as a way to stratify which patient I'm going to treat with brentuximab. And I certainly have had the experience of treating patients who are negative and have them have a clinical response, although sometimes we have to fight with our insurance companies about that. So I think in terms of thinking about this disease, you know, we talk about MF as being an immunologically responsive disease. And so if we can focus on the biology of the disease, perhaps we can understand a little bit better about how we pick novel therapies or how one treatment might work better than another treatment. And so we know that mogamulizumab is the most recent drug to be FDA approved and is certainly effective in this disease. And if one kind of focuses back and tries to understand why that may be, this slide just shows you that the extravasation of these T cells within the skin is somewhat dependent on chemokines and homing receptors. And we do know that these cells do traffic in and out of the skin. And the binding of receptors like CCR4 and other chemokine receptors is important in the interaction between these malignant cells and the skin and the epidermis. So it turns out that CCR4 is expressed in many patients with cutaneous T-cell lymphoma, and you can see on the immunohistochemistry here expression within the porträus microabscesses, as well as expression in the circulating malignant cells in the blood. So the mogamulizumab is a humanized monoclonal antibody that binds to CCR4 and effectively kills the cells by inducing ADCC. I don't know if you can see on the bottom, but there's a differential degree of expression of CCR4 across different stages of MF, but it is expressed in patches and plaques, tumors, as well as in patients with Sézary syndrome. And mogamulizumab was first approved in Japan for patients with HTLV-1 associated T-cell leukemia lymphoma, which also has a high expression of CCR4. And again, this just shows you the differential level of expression as patients develop more advanced disease with higher expression in patients with tumor stage disease and Sézary syndrome. And you can also see that psoriasis and other inflammatory skin disorders have a very low or absent expression of CCR4. There was a phase 1-2 study done in the United States, a study that I participated in, where we looked at patients with mycosis fungoides and Sézary syndrome. And early on in this experience, we did see patients with very dramatic clinical responses. And you can see some of that data here. Response rate was 47% in Sézary and 29% in MF. And the dosing schedule that we used in this trial was similar to what we're using in the registration trial. So based on those data, we went on to the open label randomized study of mogamulizumab CTCL. And you can see this included patients stage 1B and higher that had received at least one prior systemic therapy. And interestingly, though, it is important to remember that we did exclude large cell transformation. So we can't conclude anything about response rate to large cell transformation in the setting of this data. There were 372 patients randomized, and again, there's no requirement for CCR4 expression, and that's because almost all of the patients that we studied by immunohistochemistry did express CCR4. And the other interesting data to the mogamulizumab arm, and progression-free survival was the endpoint of the study. So you can see the overall response rate to Sézary syndrome was 37%. That's very similar to what I showed you in the phase 1/2 study. And with mycosis fungoides, it was 21%, as opposed to very low response rates in the vorinostat arm. And the duration of response was shown here at 13 or 17 months for the MOGA versus a shorter response duration for the control arm. What was interesting about the study was that there was a higher response rate in the blood compartment compared to the lymph node compartment. So this trial looked at skin, blood, lymph node, and visceral compartments to determine whether there was a selective response. And you can see the data shown here that the drug is highly effective in the blood compartment, perhaps less in the skin, but certainly active in the skin, and really not very active in the lymph node compartment. And again, we're still kind of looking at this data, critically analyzing it to try to figure out why that might be. This is just the waterfall plot to show you that most of the patients on the trial did have some form of a clinical response in their skin. And if we then look at symptom reduction, which we've talked about as being a very important aspect of this disease, many of the patients on the MOGA arm did have improvement in the Skindex 29 scale, as well as their itching. And the median time to worsening in the MOGA arm was about 2 years. So that's actually that's a very high number for this patient population versus 7 months for vorinostat. And I think that's an important endpoint when you talk to a patient about how a treatment is going to be effective over a period of time. The adverse events associated with this were those that would be expected from an infusion. That actually could look like respond in many cases to systemic steroids. I just want to give you a case vignette. This is one of my patients who was an older lady who had a rash and pruritus for 4 months. When she presented, she had erythroderma, exfoliation, as well as fissuring of the skin on her palms and her soles. And she felt cold like many of our patients do. They have chills without fever. And she used topical steroids but had no relief. So her skin biopsy showed epidermotropism and an extensive deep infiltrate consistent with MF. Her blood flow cytometry showed that she had a significant number of circulating malignant cells. She had a positive T-cell receptor rearrangement and her flow cytometry. And she also had lymph nodes on her CAT scan. And you can see the malignant cells shown here. She basically then had 10%, 100% erythroderma, typical Sézary patient. And so she actually was treated initially with photopheresis and then romidepsin, and she did not respond to either one of those. So she moved on to receive mogamulizumab, and she was actually on the clinical trial. And she received the drug for 12 months, and she actually had a very excellent response. She did go on to evolve a near complete response and had no infectious complications. So that's a typical patient that I would treat with this drug. I want to talk about some of the up-and-coming therapies now. And this drug, I think, perhaps will be the next one that will move on to approval. So this is IPH4102, which is an antibody targeting a KIR receptor, which is KIR3DL2. This work was done by the group in France, which identified the fact that this KIR receptor was expressed in patients with MF and Sézary syndrome. and they developed the monoclonal antibody, and they showed in early clinical trials that that antibody was effective. So there was a phase 1 study done in CTCL where they used this monoclonal antibody in patients who had prior therapy. There was no dose-limiting toxicity in this trial, but there was a recommended phase 2 dose of 750 milligrams by IV infusion. And again, the common adverse events are what you see with a monoclonal antibody. And you can see the global response duration for these patients, and many of these patients actually did very well with this antibody. And again, this one proved to be particularly good for those patients with Sézary syndrome. So I think we're going to see this approved in the next year or two. I want to mention something about checkpoint inhibitors because, of course, we're all using checkpoint inhibitors in many different settings. But the data in mycosis fungoides and Sézary syndrome is really very limited. So in the United States, we conducted this NIH phase 2 study of pembrolizumab in patients with advanced MF and Sézary syndrome. And you can see the data for this study here. It was recently published in JCO. So if we actually looked at the global response, we found the response rate was, about 35%. But if you look over on the left-hand side of that waterfall plot, you can see that there were clearly patients who actually progressed on this drug. And so that's one thing to keep in mind, and some of those patients can do poorly. And you can see the fungoides and Sézary syndrome. Perhaps it was a little bit better for the activity for checkpoint inhibitors. Perhaps that isn't as well defined, and we need to treat inhibitors. This is a patient that was not on that clinical trial, but went on to receive pembrolizumab off study. And this patient initially had very advanced, you can see advanced plaque stage disease. And he received pembrolizumab, and then you can see on the top that he had worsening of his disease. So he gradually had progression of his disease. And so when we did a skin biopsy, we found that that was an immune-mediated skin response, in that the original disease was CD4 positive, and the inflammatory response that he was having from the pembro was CD8 driven. And so we treated that patient with steroids, and initially the patient got better. But then if you look in the bottom, you can see that the patient then developed a very rapid and very aggressive acceleration of disease. And so at that point in time, we did biopsies, and we showed that this was not the CD8 mediated response, but this was his initial disease with large cell transformation that went on to essentially exfoliate him, and the patient died in the ICU. So this is an example of the kind of progression that you can see, and I've had other patients like this. So I think I would suggest that we perhaps don't pull pembrolizumab off the shelf as a choice for most of our patients with MF. Would strongly suggest that we put them in a clinical trial if one is available. So another active drug is duvelisib, which is of course a PI3 kinase inhibitor. There is a current study underway looking at activity of duvelisib in registration trial. But more important than that, I think, is now starting to think about how we combine these agents. And perhaps combinations are going to be better with more meaningful response durations. So there are combinations of duvelisib with romidepsin and the pralatrexate, which is also a very effective combination. And one of the more interesting ones now is looking at romidepsin with azacitidine, so looking at combining epigenetic modalities. And this has shown significant activity in patients with aggressive T-cell lymphoma, and also being looked at in CTCL. Well, what the NIH is doing now with pembrolizumab is that we have a trial where we're combining it with interferon gamma. That's a very small trial that's not accruing very quickly. And then in addition, of course, there are other pathway-directed drugs that are being developed. I would like to see a development of CAR T-cell therapy for patients with MF. There is a trial with a CD30 CAR in the United States that is open for patients with CD30 expressing MF. And there are other strategies that are being pursued as well for CAR T-cell. And I think the prospective registries are really important in this disease. So of course the European and worldwide ISCL group has the ProClippi registry, but the United States Cutaneous Lymphoma Consortium also has opened a registry as well. These are just my conclusions, which I think summarize most of what I talked about. And I won't read them in the interest of time, but I just wanted to say a word about transplant, because we also have been very active in leukemia and lymphoma with our experience. We do have experience with haploidentical transplantation, and what we found is that most of our patients do require either DLI or subsequent therapy, because most of them don't have a really good graft versus lymphoma effect. What we have found is that brentuximab vedotin is a very active drug to bring those patients back into remission in the allo setting, and many of those patients now have gone on to have a sustainable remission. And I would say that the group of our patients that I think did best with allogeneic transplant were those patients with Sézary syndrome. So if we can try to capture them earlier on in the course of their disease before they become multiply refractory, I think they're going to be better candidates for transplant. And that's the end of my talk. Thank you.
Thank you much, Dr. Foss. Thank you for all the speakers. We're left with 20 minutes of questions and answers, and we got quite a few interesting questions from the audience. So I'd like to start with Dr. Yousef Binamer. We have, I collected 3 questions that need dermatology help. So the first question was, what makes you think this might be a cutaneous T-cell lymphoma? Like you have a rash, what makes you think that it might be cutaneous T-cell lymphoma? This is 1. 2, is there a role for skin de-infection in these patients, like a bath or something like we used to treat patient with recurrent MRSA skin infection? And then the third question and last for dermatology is, what's the difference between PUVA, external beam, and these different fancy terms that dermatologists use and hematologists are not familiar with?
Sure, thank you for the questions. To start with, what are the features that suggest this is rash is more of cutaneous T-cell lymphoma? First, a presence of like well-defined patches or plaques, mainly in sun-protected area. These sun-protected area, mainly the buttocks and axillae. So if you have a patient that has like patches that are persistent of a regular shape, mainly on the buttock as well as on the sun-protected area, then it is suspect for me a cutaneous T-cell lymphoma. This is number 1. Number 2, if there is an area of atrophy, that means skin wrinkles at one of the like with these plaques, that means it suggests of cutaneous T-cell lymphoma. Number 3, that failure to respond to conventional treatment. For example, if you treat this patient as psoriasis and he's not responding in the right way, then probably are you missing such condition. To take into consideration that cutaneous T-cell lymphoma is a great mimicker, so it can present with anything, but the common things is patch and plaques that are persistent, usually asymptomatic, but sometimes can be even itching in sun-protected areas, mainly in the buttocks. Second question, what's the role of infection? There are 2 things. There is some theories say that actually bacterial infection can play a role in the pathogenesis of the disease. There is some old theories that super antigens from staph aureus can be one of the triggers or the aggravating factors for cutaneous T-cell lymphoma, but this seems to be unlikely. The more common, and it is very important, especially for hematologists and even for dermatologists, people who do have a skin lymphoma, they do have some sort of immune deficiency in the skin. So they are more prone to get skin infection, mainly in the stages of erythrodermic cutaneous T-cell lymphoma. This is why patients with cutaneous T-cell lymphoma, very common to have multiple skin infection. We do for them a surveillance, we do swabs. Sometimes we give them prophylactic antibiotics, and you will find that if you have a patient with erythroderma, if you give them a course, their condition is responding because there is some sort of immune deficiency. Why this happen? One of the explanations that cutaneous T-cell lymphoma, mainly Th2 disease, while most of the skin immunity is with Th1. So when you have more Th2, there will be an increase of the chance of infection, but this is mainly seen with erythrodermic type and advanced stages. This is sometimes we do something like similar to bleach bath or de-infection of the skin. We do prophylactic antibiotic. It's very common to see that one of the limiting factors to give aggressive treatment is that recurrent skin infection. We have many patients who do have advanced disease, but whenever they have in good condition to receive either a biologic or immunosuppressive treatment, they do have recurrent skin infection. So skin infection is very big problem with this patient. So therefore, you need to do frequent surveillance, sometimes prophylactic antibiotic as well, continuously. For the question, what is the difference of skin-directed therapy between PUVA and others? PUVA, you will have to have take a tablet, which is oxyrolin, 90 minutes to 2 hours before the exposure to the light. So whenever you have this oxyrolin tablet, your blood will be having more sensitivity, so it will reach more skin, and the exposure to UVA will be more effective, and it will penetrate deeper. Second thing, it has a role in the playing with the systemic involvement, mainly in the blood. Third thing, this oxyrolin is the same thing which we are using in the ACP, extracorporeal photophoresis. The principle of the extracorporeal photophoresis is to do the oxyrolin, and instead of ingestion this oxyrolin, you will inject it directly to the whole, to the white blood cell to avoid any this. Okay, so the excimer laser is a kind of laser that is driven from narrowband UVB. It's 308 nanometer. It is mainly for small areas. Narrowband, it is used mainly for the thin patches, and it is the safest one. It doesn't need to take any medication. Any question, Dr. Riad? Or?
Thank you much, Dr. Yousef. So we will move on to the other set of questions. This is a set of questions directed to Dr. Foss. And also I have 3 questions directed to her. So actually 4 questions. One, is there a clear correlation between autoimmunity and cutaneous T-cell lymphoma? 2, do you screen your patients for immunodeficiency, young patient presenting with CTCL for immunodeficiencies? And is there a role for mutations in the prognostication of these patients? And last but not least, any role for antivirals when you have viral-induced cutaneous T-cell lymphoma?
Okay, so the first question was, do I check my patients for immunodeficiency? Was that the question?
Young patients presenting with CTCL. Do we need to check them for immunodeficiency syndromes?
Well, I think, we don't understand very much about why these very young people get mycosis fungoides, right? And I've certainly seen, I think the youngest I saw was like 7 years old, and multiple like in the teens. And so I think that it would be a very reasonable thing to do. I don't think that we've really defined what the workup should be, but I think that is an excellent question. whoever posed that question, and I think certainly I need to go back to the ISCL and ask them if they would at least consider coming out with some strategies for this. In my experience, I have not seen any immunodeficiency in the younger folks, but I didn't do a really extensive workup either. I think with respect to the issue of mutations, so and looking for mutations to try to figure out what the relevance of them are. I mean, I've certainly seen people with P53, and that's associated with progression and not a good outcome. Other mutations have not been as, I think, carefully characterized. You know, there's a lot of papers published about various mutations that are relevant, but we don't have a lot of information about how relevant they are in terms of specific therapies and whether we should change our treatment approach if you have those mutations. But again, that's a very excellent question, getting to really what the next frontier is in this disease. And I think antivirals, I mean, I guess the question is, you know, if you had a patient with like HIV, I presume that's the question, because you know, I mean, we have seen a few
and
people.
HTLV and HIV.
Well, yeah, different diseases. So with HIV, we have seen a few patients with mycosis fungoides, and they're almost all on antiretroviral therapy. So it's unclear whether suppression of mycosis fungoides. HTLV1 is another whole different disease. And, you know, within the context of HTLV1, it's really hard to make a diagnosis of MF, right? I think, you know, because if you remember back, actually, the very first patient with HTLV1 presented at the National Cancer Institute, presented with what we called Sézary syndrome. And the cells were put in culture and the virus was isolated. So like there's a tremendous overlap in the clinical manifestations of those diseases. And so if somebody is HTLV1 positive, I generally don't, you know, give them the diagnosis of MF.
Okay, we have the other question about autoimmunity and if there are any mutations that are prognostic. So the association with autoimmune disease, is there a clear association, and any mutations that correlate with prognosis?
Well, it is true that we you know, more MF in patients that have various kind of underlying autoimmune diseases like, you know, psoriasis. You know, we've got people who've had rheumatoid arthritis, we've got other autoimmune diseases. Epidemiologic point of view, I'm not really sure yet that we can make a strong association. I think there's definitely an association, because I feel that there's immune repertoire deficiencies. If you look very early in these patients, even like the very early patch plaque patients, there's definitely skewing of the immune repertoire very early on in the course of the disease. So I think that would speak to the fact that perhaps many of our patients do have some underlying either polymorphisms or some underlying immunodeficiency of some sort that perhaps predisposes them to develop, you know, MF from whatever chronic antigenic stimulation is triggering the disease. So I think that that's a really like likely hypothesis for etiology of the disease. But from a practical point of view, you know, we generally don't do any kind of an extensive immune profile in these patients unless there's another reason to do it.
I see. Thank you so much. We'll move to the last set of questions, actually, for sorry, I was disconnected. So we'll move to the last set of questions for the whole panel, but specifically for Dr. Absi and Dr. Foss about what kind of conditioning, should it be TBI based or non-TBI? And so this is the first question. And then the second question is, how can you differentiate clinically between GVHD and cutaneous T-cell lymphoma? Is there any way to differentiate?
Do you want me to start that?
Yes, please.
Excuse me. So we have developed a regimen that is somewhat T-cell specific to try to target residual disease as part of the conditioning strategy. So we do total skin electron beam 12 gray, so an abbreviated course, immediately before they come in for their conditioning. And for conditioning, we use infusional pentostatin for 48 hours with 6 gray of total body radiation. So we believe that the pentostatin, of course, has activity in T-cell lymphoma, but it's also immune depleting. And the TBI, we think, makes a contribution by helping us with residual disease. So that's the regimen that we use in everybody who's not undergoing part of that regimen. With respect to how you tell the difference with GVHD, that is also a very good question and a clinical conundrum for us in many situations. Sometimes we can go back to clonality. So sometimes we can, if we have clonality data from the original tumor, we can go back and look at clonality. And in particular, if we used the adaptive molecular clonality studies where there's actually sequencing of the unique T-cell receptor rearrangement, we can use that as a kind of a probe to look at the rashes post-transplant. But even so, we've seen a number of patients that have both GVHD and persistence of their disease. So it can be very difficult to make that distinction.
Thank you much. Dr. Absi, any comment about TBI, non-TBI based conditioning and GVHD? How do you differentiate GVHD from a recurrence of cutaneous T-cell lymphoma?
Yeah, I probably won't add much more than what Dr. Foss already said, but for us at least, or for me, with the availability of the medications that we have, I mean, I'm interested to get the protocols that Dr. Foss has, but for us is, yeah, it's TBI based, and I think with the limitations, flu TBI probably would be, reduced intensity would be probably the preferable regimen here. And I agree, GVHD and recurrence of the disease are probably very challenging to differentiate. Unfortunately, for those patients, if they have recurrence of the disease post-allergenic, not much options are left at that juncture. Enough, many of the therapies, or some of the therapies that probably would be used would improve both at the same time, but it is a challenging situation, I agree.
Okay, with that, we come to the end of this webinar. I would like to remind everybody from the audience that the full recording of this webinar is available on the SSBT YouTube channel as well as Twitter account. And I would like to remind you about the webinar for the next week. It's cancer-associated thrombosis with many of our prominent thrombosis specialists here in Saudi Arabia. With that, I would like to thank everybody, and hopefully we'll see you next week. And thank you, Dr. Foss, for joining from the United States. Thank you all.
Thank you.
Thank you, everyone.